Now we are moving on to some of the other malignant tumors such as osteosarcoma and chondrosarcoma. As I just told you, in this age bracket, that is 5 to 25 or 10 to 30 years of age, in children or in adolescents, the most common primary bone tumor is osteosarcoma, and second most common primary bone tumor is chondrosarcoma. So these two are very important and has a very high rate of incidence. In this section, we are going through the osteosarcoma, how to diagnose it, how to treat it, and then the differentials of different types of osteosarcomas and types of chondrosarcomas as well. So osteosarcoma, as the word says, it's a sarcoma, it's a malignant tumor and of osteoid variety. That is, it contains osteoid matrix. Most common, as I just told you, usually the age of presentation is at 10 to 14 years of age. This is the peak age of presentation. Usually it can present from 10 years to 30 years, but usually it's always in the young adolescents or in children. Age, again, secondly, the next presentation is after the 7th decade. So it's usually less likely that in between it can present. Either it presents very early or very late, and usually in the 7th decade is usually secondary osteosarcoma, not the primary type of osteosarcoma. It's different in terms of it, that is high grade medullary osteoid producing tumor. It's spread through the periosteum, that is actually as it's producing the osteoid matrix, then it's also causing there is always new angiogenesis going on, and as the vessels proliferate they get calcified, and usually the classical presentation is of a metaphyseal lesion with a sun-ray appearance. The spot diagnosis is osteosarcoma. Usually it's metaphyseal, although it's most of the time it's metaphyseal, but it can be diaphyseal or it can be even epiphyseal as well. Less than 1% usually are epiphyseal tumors, although they're very rare, but they can be osteosarcoma as well. Major presentation is the most common area is the knee, that is the distal femur, then comes the proximal tibia, then the proximal femur, and later on the proximal humerus. And this is how it's most commonly, but around the knee, as it is most commonly found around the knee, that is the distal femur and proximal tibia. Clinical features, usually the first thing is the age. Usually in the children, as it is a malignant tumor, it comes with pain and swelling both. It's not an indolent or incidental finding. The child comes to you with a limp, with the knee swelling, a pain and everything. Then there may be associated elevate fever, and once we get the labs done, there will be raised alkaline phosphatase, as because it's a tumor of osteoid matrix. Osteoblasts are actually proliferating and they are producing large amount of alkaline phosphatase. There may be associated elevated LDH, as I just told you, it's not specific for any disease. It could be for multiple tumors that are actually producing higher levels of LDH. Then this may be associated erythematous skin with venous engorgement as well. Although this is highly rarely, but it can usually present in a SLE-like fashion or butterfly rash around the face. It's usually linked with Li-Foraminal hereditary retinoblastoma and Rothman-Thompson syndrome. Actually, the gene involved is RB gene, which is retinoblastoma gene, and usually it's the alteration in this retinoblastoma gene that it has associated with retinoblastoma as well as Rothman-Thompson syndrome. Now, coming to the types of osteosarcoma, as there are different types. Some are low grade, some are intermediate grade, and some are high grade tumors. Low grade include parosteal and low grade intermediate CA. High grades include small cell and high grade osteosarcoma. Well, intermediate grades includes parosteal and telangiectative variety. Now there are different types, as I just told you, primarily defined as primary tumor of the bone, that is called as primary osteosarcoma, usually presents the first and second decade of life, and was the secondary osteosarcoma is actually secondary to the insult due to either Paget's disease, or it is secondary due to for any other reason such as radiation therapy being done to that bone, that usually presents late in the life in the 6th and 7th decade, and that is termed as secondary osteosarcoma. As I just told you, it's secondary to Paget's disease and radiotherapy. Other associations with the secondary osteosarcoma include myxofibrous tumor, osteomyelitis, or dedifferentiated chondrosarcoma. Diagnosis: How to make the diagnosis? The first thing is to get an X-ray, and we know that usually first we know the age of the patient. Most commonly, the lesion is metaphyseal, although it can be diaphyseal or even epiphyseal. But usually, it's the osteoid-producing radiopaque lesion with this classical sun ray appearance in the metaphysis. Then it actually makes a diagnosis. Then we have to get an MRI to see the soft extension of this disease. Then nuclear medicine or bone scintigraphy would reveal whether it's a single lesion or multiple lesions. And it has propensity to metastasize to chest. So we need to get CT of the chest to first of all to know whether there is metastasis to pulmonary area or not. And if pulmonary mets are present, then how many of them are, whether they are more than 6 or less than 6, and whether they are large size or small size actually determines the prognosis of the disease. So if there are multiple mets and small size mets are present in the chest, then the prognosis despite the adequate treatment is very low as far as osteosarcoma is concerned. And once we have made the investigations, all the blood workup and non-invasive investigations done, to confirm our diagnosis, we have to go for a biopsy, and biopsy would reveal osteosarcoma. So coming to usually the treatment is basically when we is involving the lower half of the femur. So we see as an osteoid matrix, and usually this once periosteum gets ossified, it presents a classical tenting of the periosteum called as formation of Cordman triangle. Coming to the treatment, depending upon whether it's low grade or intermediate or high grade. Usually intermediate and high grade are treated as one entity, and low grade osteosarcoma is treated as the other. But treatment involves neoadjuvant chemotherapy with doxorubicin and cisplatin as given. Then once the tumor is down stage, then after giving the multi-agent neoadjuvant chemotherapy, then we go for wide local surgical resection. Usually after resection we have to go for reconstruction because it's mainly involving the knee. If you see it over, this was probably a tumor of proximal tibia which has involved quite a lot of it, and then they have taken it all out, almost all the proximal tibia is out, and reconstructed with the endoprosthesis or megaprosthesis. Other options could be that probably if we know that there's not enough margins are available, and primary amputation could also be a good option, given that taking the above knee amputation is done and given a good fitting prosthesis, probably that would be more helpful for that child as he or she is going to grow, rather than for endoprosthesis, which is more cumbersome and which may be associated with more complications. The other includes rotationoplasty. This is actually a new surgery in which if the tumor is present around the knee is actually taken out. We know what is above the knee, hip area is intact and ankle is intact, and actually ankle is attached towards the knee in a rotating fashion, so that ankle functions as a knee in form of rotationoplasty. Although now it is done rarely, usually in children we have elongating prosthesis in which they can expand over time. Then coming to the resection of pulmonary mets, if there are less than six numbers of them, they can be resected. But if there are multiple, then we do not need to resect them. We have to give them post-operatively adjuvant chemo and radiotherapy for the treatment of osteosarcoma. Now coming to the variants of osteosarcoma, as I told you, there are different types of osteosarcoma such as low grade, intermediate, and high grade. So rare subtypes is telangiectatic type. Although why it is called as rare type, because most of the osteosarcoma are usually radiopaque and they present with a calcified mass like lesion, or they appear white on the X-ray, except telangiectatic variety, which appears lytic and usually appears in the epiphysis rather than metaphysis to diaphysis. Other include small cell osteosarcoma. This is a high grade variety of osteosarcoma, and the treatment has to be very aggressive, followed by neoadjuvant chemo, surgical resection, joint stabilization, and adjuvant chemoradio. Now they usually presentations could be multiple, especially in case of telangiectatic variety, as it's highly malignant. Sometimes it can present with pathological fracture, but as they should all be treated, all the intermediate and high grade tumors should be treated as high grade osteosarcomas. Now, I've just told you that usually osteoid matrix is present always there, and in MRI, there are multiple fluid levels because there is lytic lesions. Usually, for small cell, the regime is same, but you have to give neoadjuvant followed by resection. Now, these parosteal and periosteal, these are usually low grade. Parosteal sarcoma, it's low grade on long bones, it's common in females and radio dense mass, is as it appears, and cellular fibroelastic tissue diagnosed by MRI and radiographs. Now, the point is for low grade tumors, we don't need to give neoadjuvant chemotherapy. We have to give them wide local resection followed by chemotherapy rather than giving neoadjuvant chemo for them. But if it comes out to be on biopsy either intermediate or high grade osteosarcoma, then the treatment options totally changes to neoadjuvant chemo followed by resection followed by joint stabilization and adjuvant chemo. Coming to the periosteal is although rare chondroblastic intermediate grade tumor in diaphysis. As it is intermediate, there has to be treated with neoadjuvant chemo followed by resection and followed by adjuvant chemo. Coming to the secondary osteosarcoma, as I told you, usually either secondary to Paget's disease or secondary to radiotherapy, on which previously the radiotherapy was done for any other disease in that area. Usually common if it presents with pain, pathological fractures, and usually called as either Paget's sarcoma if it is present as secondary to Paget's disease, or called as radiosarcoma or post-radiation sarcoma if it is presenting secondary to radiation therapy. Treatment is chemotherapeutic and surgical treatment, same as for high-grade osteosarcomas. Now, coming to the chondrosarcoma, as the word suggests, it's a sarcoma malignant tumor of chondroid variety. It's heterogeneous and slow growing, and usually it's the second most disease in old age. In 40s and 50s, it presents, and the second most tumor of the primary malignant bone tumors. Usually, it involves membranous bones, such as flat bones, such as pelvis, sternum, scapula, and all these areas. Therefore, it usually presents a deep pain, enlarging mass, usually mainly in the proximal femur, pelvis, and proximal humerus area. Malignant lesions, less than 1% of the chondrosarcomas could be malignant. Most of the time, what happens is that it actually arises from pre-existing chondroid lesion. For example, there was enchondroma if the patient had Olier's disease or patient had Maffucci disease. Usually there are multiple enchondromatosis. In this case, any of the enchondroma which is present can differentiate into a malignant chondrosarcoma, and usually these chondrosarcomas primarily arise to these pre-existing lesions, eventually metastasizing into a sarcoma. There are different forms based upon location, benign or malignant chain, cell type. Usually it's called as they're large intraosseous and osteolytic tumors. Honeycomb or popcorn calcification, as they are of chondroid variety, then the classical representation is usually in the epiphyseal region, and there's increased intense calcification. That's called as popcorn appearance or speculated calcified lesion. Usually they appear on the X-ray. And endosteal cortex scalloping is usually seen due to cortical destruction, as it is a malignant tumor. They usually grow along the medullary canal, and they may be associated with soft tissue extension, especially in case of pelvic chondrosarcomas. They are diagnosed again on the history examination, CT, MRI, bone scan, and biopsy is done basically to diagnose a disease, and then once we are sure about the differentials, then we have to plan treatment. Other features of this chondrosarcoma include 60% usually have a mutation in IDH1 and IDH2 gene, classified according to the grade, such as grade 1 are atypical tumors which are locally aggressive and low metastasis, or high grade 2 and 3 tumors usually. Now, according to the grade is actually seen in the, once we have taken the biopsy, we can mention the grade of the disease, how aggressive this tumor is. If it's high grade, it has to be dealt aggressively. If low grade, it still needs to be dealt aggressively, but not as aggressively as compared to high grades. So low grade are usually intralesional curettage, radiofrequency ablation is enough. For high grades, wide local resection followed by They are usually resistant to chemotherapy and radiotherapy, but after wide local resection, radiotherapy may be given in some cases only. Types include, as I told you, one of the types is secondary or central type of chondrosarcomas. They are usually benign enchondromatosis, limb shortening, and usually present with pathological fractures. They may be unilateral or bilateral, and genetic predisposition to other carcinomas may be common as well in these. Or they can be secondary types include either it's peripheral, which are usually in the not in the exoskeleton but in the long bones. They may be secondary to osteochondroma or exostosis, which is seen in the pelvis and scapula. In people with a diaphyseal achalasia, they may be present with having a secondary chondrosarcoma. There is a mutation in EXT1, EXT2 gene which predispose them to development of chondrosarcoma from osteochondroma. Then there is periosteal lesions, which are from the periosteum of the metaphysis. They presents with pain, swelling, lobular mass, and usually sun restricts newborn formation, which is classical presentation of osteosarcoma, but they may be seen in case of chondrosarcoma. Usually, then there's a variety called as clear cell chondrosarcoma. It's in epiphysis and is low grade. Usually presents with joint destruction, lesions, sclerosis, and calcifications. Then there is mesenchymal type as well, which is highly malignant and poorly differentiated, and it's usually presents in the areas of the anatomical sites, morely in the epiphysis, and it has more aggressive and poor prognosis. Therefore, in this section, we have gone through osteosarcoma and chondrosarcoma. Both are highly malignant tumors. Usually, the most common is metaphyseal region for osteosarcoma and epiphyseal region for chondrosarcoma. Treatment includes for osteosarcoma is whether if it's low grade, wild local resection followed by chemotherapy. If it's high grade, neoadjuvant chemo, wild local resection, joint stabilization followed by chemotherapy. And if it's chondrosarcoma, the treatment is wild local resection, maybe radiotherapy given post-operatively, although there's usually chemo and radio resistance. Thank you very much. Keep watching sqadia.com.